I'm Kathy Brett with Becker's Healthcare and moderator for today's program. The program will begin with a presentation, and we will have a question and answer session following completion of the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenter will attempt to answer as many questions as he can during the time we have, and will follow up on questions he does not have the opportunity to address. You will receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after completion of the program. You can submit your feedback or any additional questions you have at that time. This email will not include the presentation. It is now my pleasure to introduce today's presenter. Dr. William Mohlenbrock is founder and chief medical officer of Varus. Dr. Mohlenbrock has practiced orthopedic surgery for more than 25 years at Scripps Memorial Hospital in La Jolla, California, and is an assistant clinical professor of surgery at the University of California in San Diego. In 1983, he founded Varus Limited, which assists physicians with voluntary clinical quality and cost efficiency improvements. Dr. Mohlenbrock received his BS degree from the University of Illinois and his MD from the St. Louis University School of Medicine. He holds fellowships in the American Academy of Orthopedic Surgeons, American College of Surgeons, and the American College of Physician Executives. It is now my pleasure to turn the floor over to Dr. Mohlenbrock to begin today's presentation.
Thank you, Kathy, and thank you all for signing on. As she stated, I practice orthopedics at Scripps in La Jolla. However, a lot of people want to know how an orthopedic surgeon gets involved in this sort of thing. I was one of the original researchers in the issue of severity of illness in 1983 when the DRGs came into existence, just because I was concerned, like many of you are, that the DRGs are averages, and if your patients are sicker than an average, why, you might look bad on the mortality and morbidity rates. And anyway, that's how I got involved in this. Today we're going to talk about physician variation, and the goal of today's presentation is basically to show you how very small changes in physicians' practices and monitoring their variation and reducing that variation can create tremendous cost savings. And I'm going to demonstrate how each physician's best practices are assessed, and then how you can integrate that with your hospital case management to improve both the clinical and operational efficiencies. So we're going to start on the first slide here by looking at, go ahead and change the slide if you would, Kathy. By looking at the 4 clinical case management focus areas. Again, the goal here is to reduce the clinical and operations variations. Number 1 is we want to look at the hospital and all of the physicians' clinical and operation variations. Then I'd like to talk about the documentation integrity, because as you all know, a tremendous amount of money is lost if the hospital and the physicians aren't documenting appropriately. And number 3, this is where it really makes the difference, to be able to have the information to show each physician, each individual physician, what their clinical practice patterns look like. Because most chief medical officers would like to be able to sit down on a daily basis and go over with their physicians how much variation there is and what they can do to improve. However, we just don't have, most CMOs just don't have that much time. So I just want to show you the kind of information that you can bring to bear to do that. And number 4 is how you can identify and then objectively demonstrate how your clinical quality and cost efficiencies are improving. And I want to spend a little time near the end here to talk about bundle payment distributions, because a critical area in the future is going to be when the hospital gets a bundle payment, it's going to be up to the hospital to distribute those dollars between the hospital and the physicians. And sometimes if you don't have really good clinical data, it's going to be rather contentious, if you know what I mean. So next slide. Slide, Kathy. There we are. Now, the first thing you want to do is anytime you're doing any kind of an assessment, you want to find out what it's going to mean to your bottom line. So let's just talk about the goal of reducing variation. And we usually at Varus, we usually try to pick either 6 or 8% reductions in variation in this particular 200-bed hospital that I'm going to demonstrate to you. By looking, first of all, at the top 10 DRGs, they're at the top, starting with major joint replacements. If you look at the 10 top DRGs in this particular hospital, and then you say, okay, like total joints are associated with the musculoskeletal service line. Septicemia is associated with the infectious disease service line. So you want to take your top 4 or 5 service lines and say, if we reduce the clinical variations in our major DRGs, what would it amount to? Well, in this particular hospital, the cost savings for the first year we would anticipate would be a little bit over about $2.4 million, and that's cost, that's not charges. So that's the way we would start off by assessing what kind of value this kind of program or a process should yield. And again, the target is 8% reductions in variation, and this particular hospital has an overall charge-to-cost ratio of around 25%. Next slide. First thing that we have to do is risk-adjust the data, as you all know. And most of your hospitals have risk-adjusted data. So I'm going to try to give you just some ideas about how you might use your data to make improvements. What we have done is subdivided each DRG into 5 levels of acuity. These patients all happen to have pneumonia. But if you look at the age, gender, and secondary diagnosis, principal diagnosis being pneumonia and the secondary diagnosis, you can subdivide these DRGs. And if you'll notice over on the left-hand side, the mortality rates for the acuity level 1 patients who are very sick, the expected mortality rate is about 2.1%. Length of stay anticipated in this particular region is around 5 days and charges around $12,000. Now, to the right, the acuity level 5 patients, we expect a mortality rate of 37%. Huge difference. Even though these patients are all in the pneumonia DRG, there's huge differences. And the thing that I like to point out to the physicians is look at the mortality rate expected in the level 2s. It's 2%. It doubles between 2s and the 3s to 5%. It doubles again to the 4s, and then it triples for the 5s. And every single DRG looks basically the same. But the point that we want to make here is that if the patient comes in and the physician is treating a legitimate 5, and yet the physician has not documented appropriately, so it makes it look like the patient is only at a level 3, you can see that the mortality statistics are going to really be off, and it's not going to be in the physician's or hospital's favor. So we'll point this out as we go along. Next slide. So once we know the mortality and morbidity rates, and the first thing that we do is we look at each service, that is orthopedics, cardiology, etc., and we look at the actual versus the expected mortality rates. Then we look at the various clinical indicators of quality, the rate-based indicators of quality, and we always do this over a 3-year period. We're looking for trends. We don't want to just compare one year to another, but over the last 3 years, are the mortality rates acceptable, and are the clinical indicators of quality acceptable? For instance, if there's a mortality problem in orthopedics or cardiology, you don't want to start talking about efficiencies. You want to solve those problems first. But let's assume, as we did in this hospital, because we've already looked at the data, that the mortality rates and morbidity rates look good. Then we put the patients on a grid that looks like this. This is what we call a best practice analyzer. The horizontal line, the 0 line, is the charge, not the cost, but the charge norm for this particular area of the country or a city. If the patients are above that line, they were managed with greater efficiencies. It's better to be above the line. More efficiencies, fewer dollars, Below the line means they were managed with less efficiency, so the doctors are using more dollars than anticipated. To the left of that vertical line means that patients have been discharged late. To the right of the line, they've been discharged early. So in the green area, the right upper hand quadrant, this is where the patients have been managed most effectively and efficiently. We've already looked at mortality rates and morbidity rates now, and there's where our areas of efficiencies are. So when I'm speaking with a group of physicians, I usually like to ask them, because none of those of us that practice medicine think about our variations. And the docs simply don't realize how much variability there is in the way they practice. So I like to ask them, within 2 standard deviations, that is where most of the cases occur, how much variation, if we take 20 cases in the right upper hand quadrant and 20 cases in the left lower hand quadrant in the red, how much variation do you think there will be, let's say in this particular hospital, congestive heart failure? And I usually get answers like, well, we all trained at the same places, we read the same evidence-based literature, maybe there's a $500 difference. Well, could there be a $1,000 difference? Well, maybe. How about $5,000? Oh, no. Could there be $10,000 difference? And they're always say, no, that wouldn't be that much variation. So now we have to, next slide will show us how much variation there actually is. Now, to get these data, in this particular hospital, we're using MedPAR data. We're using the MedPAR file simply to show the physicians how much variation there is, but the MedPAR file, keep in mind, is 2 years old. So that isn't how you look today. So when we're actually doing this analysis in a hospital for the physicians, we never use MedPAR. I just want to show you, using MedPAR data, how you can assess the variations. So we always use up-to-date data when we're actually in the hospital working with the physicians. But this particular case is MedPAR. So each of those numbers that you see there is a patient and that patient's acuity level that has heart failure. So you can see that there's rather wide variations. And if you look in the upper right area there, you can see 1, 5, and you can see some 4s. And there the physicians utilized around $40,000 less than anticipated, given how sick their patients were, and discharged the patients. If you look down at the bottom, you can see they were discharged around 5 days early. Within those 2 standard deviation ovals, you can see that the physicians are overutilizing by about $40,000. So you can see that there is a variance there of around $40,000 on the plus side, $40,000 on the negative side. Therefore, there's around an $80,000 per case variance. Now, we never say that that's bad or good. It's just a wide variation. So we want to make sure that the physicians understand that we're not using these data in a punitive way. What we want to do is show them in the right upper hand quadrant that if you want to know where there's excellence, look no further than your hospital, because you're underspending by $30,000 or $40,000 a case and discharging the patients 4 to 5 days early. Our job now is to recognize what we all did in the right upper hand quadrant and do more of that. Put that into a clinical pathway so that we will reduce variation and improve. Now, you can see that there are 3 ovals. Those ovals are from 2008, 2009, and 2010. And you can also see that there's no difference in those ovals, basically. In other words, there's been no improvement. So we're going to measure how much variation there is. We're going to measure how much variation has been improved by measuring those ovals. And in the left lower hand quadrant, we're going to analyze those cases to find out why those complications are down there. All those cases in the lower left-hand quadrant are usually some sort of a complication that have given the patient such long length of stay. So we can learn all sorts of things from this slide. Next case, or next slide, I mean. This is an exaggeration of what we want to see happen. We want to see a large oval with a mean, it's in the left lower hand quadrant. Then by focusing on those cases in the right upper hand quadrant, what will happen is those ovals will start to reduce, the mean will start to move up and to the right. And when you move that mean just slightly, what will happen is you will save tremendous number of dollars. And I'll show you what I mean. Next slide. In this particular hospital, in this this one DRG, we see that we've got an $80,000 per case variance. The zero, the little white zero, is the mean for last year. If we move that mean up and to the right, just where the X is, how do we do that? By focusing in those cases, those processes in the right upper hand quadrant. If next year we move that mean from the 0 up to the X, in this one group of patients, we'll probably save between $2 and $3 million in this one DRG alone. Now that's $2 or $3 million of charges, but it will also amount to hundreds of thousands of dollars of cost. Next slide. So that's the goal. Same hospital. These are the large and small bowel surgeries. This is just to show the general surgeons how much variation they have in their practices. And you can see that there are huge variations. In the right upper hand quadrant, they're underspending by about $50,000 per case. In the left lower hand quadrant, they're overspending by around $100,000 a case, giving us $150,000 per case variance. Now look at the ovals. You can see that they actually last year from 09 to 10, they reduced the size of that oval slightly. They did that by moving the oval to the right. In other words, they decreased the length of stay in those cases over the last year by about a day or so. So there was some improvement, but they didn't move up. They didn't become more efficient in terms of their charges. Now I want you to look at the case mix of these cases. How many 5s do you see? Not very many. This brings up the next point, the second focus that we want to focus. I'm not going to show you how we do this in terms of data, but I just want to show you that when you demonstrate to the doctors the percentage of 5s and 4s that they have compared to the 1s, 2s, and 3s that aren't very sick, if the doctors see that they don't have very many 5s in this DRG, it may mean that they're treating people who aren't as sick as they think they are. But usually that isn't the case. It's usually that the doctors aren't documenting adequately. And that means that their mortality rates could look bad. And the point that I want to make to the doctors in this score is that the federal government is starting to, and journalists are starting to publish physicians' names in newspapers based upon these data. And if your documentation isn't adequate, it will make your mortality rates look like your mortalities are too high. So I just want to point that out to the doctors because it's a very important point, and how important documentation is, not only to the financial well-being of the hospital, but why it makes a difference to the individual physicians. Next slide. The third focus is the important one. How are we going to get the data down to your individual physicians so that they can see that they are motivated to make a change? We do this by assisting your chief medical officer with one-on-one, working with the physicians, starting immediately. We want to facilitate voluntary quality and cost efficiency improvements. And we don't only want to focus on the physicians. We want to focus on all aspects of the variation, because the doctors know that there could be some operational issues that are not allowing them to get the patients out of the hospital, let's say, on the weekends. Because it's often the hospital practices and the management capabilities. Maybe you don't have enough case managers. Whatever those issues are, these kinds of data will bring that out, and the physicians will then be able to talk to the administrators with objective data to say, hey, the data shows that we can't get the patients out on the weekends. And this is very empowering to the doctors to be able to have objective conversations with the chief medical officer and with the operations organizers of the hospital. Next slide. Now I want to get this down to the individual doctors. We not only show how much variation there is at the patient level, we roll these patients up to show each doctor. We never use physician names or numbers. We just want to show the docs where they are, and each doctor knows that I'm Dr. B or I'm Dr. C. Everybody thinks that they're Dr. B, but sometimes they're not. The point is that I want to focus on Dr. C. And in this particular DRG, Dr. C has cases in the right upper hand quadrant, and they're in white, and in the left lower hand quadrant, and those are Dr. C's cases. Now, we want to focus on those cases in the right upper hand quadrant, because the cases in the left lower hand quadrant may have nothing to do with Dr. C's practice, in that Dr. C is just the responsible physician. For instance, in my group, the doctors make rounds for the other doctors on the weekends. And if I discharge a patient that is my partner's patient, that may appear to be my patient when in fact is I absolutely ordered nothing on that patient. So some of these cases, Dr. C may have nothing to do with, and that's what I meant when I said a minute ago about the federal government is publishing physicians' names associated with their outcomes, when in fact is that data could be very flawed simply because the attestation is not correct for the physicians. But aside from that, let's take a look at Dr. C and focus in on the difference between Dr. C's practice and the other doctors, because we're going to be, first of all, comparing Dr. C only to himself. Next slide. So the next level down, we want to show in the right upper hand quadrant, in this particular case in radiology, we want to show the group that in those cases that are acuity level 1s, 2s, and 3s, and this is an important point that I want to make to everybody, do not try to create a clinical pathway around a DRG, because those cases are too heterogeneous. Pick the 4s and 5s because they're relatively the same and create a clinical pathway around those patients, and pick the 1s, 2s, and 3s, and you can create one around those. But don't try to mix those cases because they are not the same. So in this particular slide, we see that these are only acuity levels 1s, 2s, and 3s. And we can see that in X-ray or radiology, in the right upper hand quadrant, the doctors as a group are spending around $1,200 of costs in those cases. In the left lower hand quadrant, we can see they're using around $1,900. That means that there's a $750 difference or variation between those cohorts of patients. And you can see in pharmacy, there's a difference of around $800 in the right upper hand quadrant and $1,400 in the left lower hand quadrant. So there are wide variations for the doctors as a group. Now let's focus only on Dr. C with the next slide. The next slide will show us and show Dr. C, and let's focus in the middle of this slide on the laboratory. Now we're talking about costs, we're not talking about charges. And Dr. C in the green, that's in the right upper hand quadrant where he's more efficient. This happens to be a he, that's why I said that. He can see that in the laboratory, his costs, read over to the left, and you can see that his costs are around $700. But in the red, his costs are around $1,700. That means in this one group of patients in the laboratory, sometimes he uses a lot of resources and sometimes less, for about a $1,000 variance. And you can see in his CT scans that he's using around $300 in the green and around $1,300 in the red. So he can see that where he has the widest variation. So again, we're not comparing Dr. C to Mayo Clinic here. We're talking Dr. C to his own practice. Now what the doctors really want is what's in the next slide, which is the ability to compare themselves to their peers. The light green is the peers. In the laboratory, the physician, Dr. C, can see that he's actually more efficient than his peers. He's using $700 versus $800. In the red, however, he's quite inefficient compared to his peers. He can see that in his CT scans, he's almost identical with his peers, but much less efficient in his red. Now, keep in mind, we have already looked at mortality rates and morbidity rates. So we have a relatively homogeneous patient group where we know the outcomes in terms of morbidity rates and mortality rates look good. Now we're just talking about efficiencies. Next slide. We can then take this down to the next level so that Dr. C, and this is a different hospital, but Dr. C in this particular hospital can see, well, what's going on here in pharmacy? Because I'm using $25,000 in the pharmacy over on the right side in the right upper hand quadrant, and in the left lower hand quadrant, I'm using $98,000 per case. And again, this is only for levels 1, 2, and 3. So huge variations in this particular group of patients. Next slide. We can then take this down to the individual drug or laboratory test or whatever. When you have it, when it's this granular, the doctor then can see that in the right upper hand quadrant, he's using around $2,500 in a case, and in the left lower hand quadrant, he's using around $12,000 a case. He can see that the length of stays are around 2 days difference. He can see how many cases he's had, and huge variations in the way each of us practices. Again, this is not bad or good. It's just a means of demonstrating to the doctors their own data compared to their peers. Next slide. What we want to then do is to be able to focus in the right upper hand quadrant for the entire group. Because when we have the technology and the decision support tool that drew all the graphs that you just saw, many of your hospitals have this type of a tool where you can do this. And I just want to demonstrate some ways of doing that. This particular tool is called Sherlock just because it asks the right questions. But we want to show the doctors in the green or the right upper hand quadrant what all the doctors did working with their own nurses, working with their own respiratory therapist. What did we all do in our treatment patterns in the in the right upper hand quadrant? And we can break this down in a very granular fashion to see what we all did up there, because we want to take those processes, and those are the ones that we want to then create our best demonstrated clinical pathway. And for those hospitals, most of you are doing this or already, or you're moving toward CPOE, where the physicians are going to be doing the order entry. We want to be able to demonstrate, you want to, in your own hospital, demonstrate what we all did over the last 3 years that gave us the best outcomes. And that's where we want to focus. That's where we want to say, this is what we did in last year that gave us the best outcomes, and let's do more of that. Because if you do, what will happen is those ovals will start to shrink, and you will start to move up and to the right. And when you have the granularity to be able to take this down to every severity level by age range, then the doctors become really interested. You're not comparing them to some other institution. You're comparing themselves to themselves. And every one of you can think of a doctor who is going to say, well, I'm not doing this. I don't care about this stuff. My experience is that the vast majority will buy into this because, again, you're comparing themselves to their peers. But even the ones that are really, the doctors who are really recalcitrant, you start presenting these data to them, they will start to change, no matter what they say. Next slide. You can then take this down to the various areas and look at orthopedics or the emergency room, and you can actually show in actual dollars how many dollars are saved. This is what I mean by being able to take, basically show the hospital how many dollars. In this particular case, we said it was going to be over $2.5 million. This is how you document exactly in each area how many dollars have been saved using these techniques on not only the clinical reduction in variation, but also the operational reductions in variation and cost savings. Next slide, please, Kathy. So that's the focus of how we're going to demonstrate this. Now I want to show you some other techniques, and this is called the Index of Quality Improvement. This is so you can demonstrate to your physicians, to the hospital administration, and to the purchasers in your area that you have the highest quality, most cost-efficient group in town. So what we've done is we've taken these various areas. In this particular case, a hospital that happens to be an ACO. Over on the left, we've taken the National Hospital Quality Measures to see how the hospital stacks up against other norms. Patient satisfaction is next. Mortality rates, then morbidity rates in red, reductions in variation in light blue, resource consumption. This is a measure of the inflation rates basically over the last 3 years, and everything is done here in 3-year increments. And the ACO measures, and each one, the height of each of these bars represents how many dollars, how much variation has been improved in each of these areas. And you can see that mortality in red gets more, morbidity in red gets more points than mortality, which gets considerably more points than patient satisfaction. And these are just experiential. That is, this is what we've learned over the last 25 years as to which of these measures are the best indicators of overall quality. So when you stack these one on top of the other, we have over on the right-hand side, this particular hospital F, that is over the last 3 years, the index of quality improvement over those years. Next slide. And the reason this is important is because when you compare over on the left-hand side, each of these measures to show over the last 3 years in this particular hospital, when you started this process on July the 1st, you want to be able to measure at the end of the year over on the right-hand side which of these measures have improved and how much. You can see that there has been improvement in this particular hospital over the last year. And the reason this is important to be able to show this in a graphic form, because not only do the physicians, are they able to see this, but as administration and the board, it's very simple to read this. The higher the bar, the higher the 3-year improvements in these hospitals. Next slide. You can then start to answer the question of how are we going to objectively show the physicians how many dollars they should get if they improve more over the last year. How many dollars should the hospital keep if we have an ACO or a bundle payment distribution? How many dollars should the hospital keep, and how many dollars should the physicians get? Next slide. We have a sliding scale that shows us how many dollars the physician should get. The more the physicians improve, the more they should get. So if you have, let's say, a multiple hospital ACO, let's say that you have 4 hospitals in your ACO, and you have $10 million to divide up, you'd better have some pretty solid metrics to show that hospital A gets $1.5 million versus hospital B, which gets $3 million, hospital C gets $2 million. That's the first breakdown. The next breakdown, as I said a minute ago, how much should the hospital get? Well, if the physicians have done a really good job in improving, they would get, let's say, 60%. And then the next question is very important. let's say that the physicians get 60%, but how much should the orthopedic surgeons get versus the cardiologist? So if you have the data,
to be having some internet connections here on our end. Just wanted to make sure, are you still on the line? Good afternoon, everybody. We've had a connection problem with, and want to know if you are still there. If you'll bear with us for just a quick moment, we'll get Dr. Mohlenbrock back on the line.
I just don't have, I don't know what my audio code was.
Dr. Mohlenbrock, are you there? Just one moment, please. We're sorry about this delay.
What's his number?
We'll be with you momentarily. Again, my apologies for the delay.
Hello?
Dr. Mohlenbrock, we are
Yes.
ready to continue the presentation. So sorry about that. We had an internet outage in the Chicago area.
Okay.
But everybody's still on the line, and we're ready to continue. Again, attendees, I apologize for the delay. If you would like, we can continue on.
Go ahead. I can't.
Okay.
Show me
The last slide. You were on slide 22, which was bundled payment.
Okay. If you'd show that to me.
Okay. Are you dialed in? Because I believe
Okay.
everyone can see that slide.
Okay, that's fine.
Okay.
Okay. Isn't technology wonderful when it works?
When it works.
Bundle payments. Okay. Not exactly sure where we were, but what I want to talk to you about now is we are rapidly moving into an area where the federal government is going to be moving away from private fee-for-service for physicians, and we're going to see more and more bundle payments. And the question is, how can the hospital objectively show the physicians how many dollars they should be receiving and how many dollars the hospital should keep? Can everybody, Kathy, can they hear me?
Yes, everyone should be able to hear you.
Okay, fine. So let's assume for a second that you have a $10 million net surplus and you have a 4-hospital ACO. The first question is, how many dollars should each hospital get of that $10 million? You need good objective data to be able to demonstrate that for physicians. The second question then is, the hospital gets $2 million, let's say. What percent should go to the physicians and what percent should go to the hospital? The physicians, the more efficient they are, the more dollars they should get, because the hospital is going to make up the difference on Medicare and Medicaid. As the physicians become more and more efficient, the hospital will do very well on Medicare and Medicaid. The next question then is, how many dollars should the orthopedic surgeons get, and how many dollars should the cardiologists get? Next slide. The index of quality improvement is a means by which we can show in very graphic form, not only the physicians in the hospital, but the board. The higher the quality, the higher the bar. So in this particular hospital, let's say there's been a $1.4 million savings between the start date at on 1/7/12, that is July the 1st, to the next year. You can see exactly where the improvements have been made. Next slide. Of this $1.4 million, the hospital is going to get to get that $1.4 million, each ACO or co-op will determine what factors go into how many dollars the hospitals get. But in this case, the hospital gets $1.4 million. There's a sliding scale for the physicians, and let's say the physicians have done a good job, and the physicians are going to get 55% of that. That means the doctors are going to get $1 million. And it's all objective, so at the front of the year, we know exactly who's going to get what. The next question is, what percent should the hospitalists get, the neurologist, and the neurosurgeons, etc.? When you have objective data, you can then answer these questions in a very objective, non-confrontational manner. That's why having solid data is the key. Next slide. So, again, helping the physicians understand how much variation they have and how to reduce that variation makes huge differences to the hospital's bottom line, and ultimately to how many dollars the hospital gets and how many dollars the physicians get. So with that, I would like to open this up to questions. Kathy, you want to ask me the questions, or how we'll proceed?
Absolutely. Thank you for a very informative and enjoyable program. Again, my apologies for the internet outage. As a reminder, you can submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Dr. Mohlenbrock, we do have a few questions here. If you're ready, I'll start with the first one. This question is for you. Is Scripps Memorial utilizing these tactics to reduce variation and improve cost savings?
That is being considered at this time. They have in the past. They have been doing some other things on their own at this point. They are not active at this right now, but anticipating we will start that in the not-too-distant future.
Thank you. Dr. Mullenbrock, how confident are you that you can achieve these cost savings you just have shown us?
The cost saving, in this particular hospital, we were anticipating, I think it was $2.4 million. Because we've done this on a number of occasions, we're very confident that those kinds of cost savings can be achieved. And as a matter of fact, our particular organization, Varus, we guarantee our savings. That is, we guarantee that the hospital will not pay us more dollars for doing this than we can save them. So we feel that's a guarantee, and so we feel very strongly that we can save those kinds of dollars.
Okay, great. Thank you. We have a question here regarding earlier in your presentation when you were talking about charges. She will ask, do the charges include the LOS?
Yes, they do. These are total charges, and that is associated with LOS. Yes. So as you reduce variation and reduce length of stay, the charges will come down.
Okay, thank you. This next question, it seems that documentation is really important to this whole process. Does your company provide experts in coding and documentation?
No, we don't. There are many experts out there, and what we can recommend those, but we don't do that ourselves. There are experts that do that, and it's, in my estimation, that's the hospital should really think seriously about that if they find that they have any kind of documentation integrity problems.
Okay, great, thank you. This next attendee would like to know what percentage of physicians maintain this best practice.
That is a critical question, because what we want to show the physicians is that basically every physician does. That is, if each physician looks at his or her pattern, they will see patients in the right upper hand quadrant and the left lower hand quadrant. This is not about bad doctors or good doctors. It is about what they all did in the right upper hand quadrant to demonstrate each doctor's best practices and focus in on those practices to create the clinical pathways. Again, this isn't about bad doctors or good doctors. Each of these doctors will have cases in the right upper hand quadrant, and that is a critical question, and the physicians want to know that. They don't want to be looking for bad doctors, and we certainly don't do that. We want to look at all the processes in the right upper hand quadrant and replicate those.
Thank you, Dr. Mohlenbrock. This next question is it necessary for Varus personnel to conduct the one-on-one data sessions with the physicians, or can our CMO do that?
Oh, good question. The CMOs can certainly do this. Our experience is that they simply don't have time. There are so many demands on the CMOs. They can't sit down with doctors on a daily basis and do this, and that's why we've adopted the method that we have of being the CMO's right-hand person to come in and help them do that. And that's a critical question, and our experience is that getting the data in the physician's hands very, very frequently is what the doctors want. They'll start asking for these data, want to see how they did in this group of patients versus that group of patients, and why am I here and not there? Those are the kind of questions that need to be answered very rapidly for the doctors, and they will stay very engaged if you do that.
Okay, thank you. How do they define ACO metrics?
ACO metrics, you will recall, the federal government has determined, they started off, remember, with 55 metrics. They are now down to 31, and these are designated by the federal government. For those ACOs that are designated ACOs, they have chosen these 31, and we just take those 31 and find out how they did from year to year, and we put those into the ACO metrics.
Thank you very much. How do you pull the specific data out of our computer systems to show the data to our physicians? Excellent
question. The data that I showed you on the 4-quadrant graphs were done by a technology called Sherlock. It asks the right questions. We have another technology called Watson. Obviously, Watson helps Sherlock. Watson pulls the data out of the lab, the pharmacy, and the x-ray so that we can get this down to the granular level. And we've worked that out with the hospital's IT department to be able to pull that data together and then merge these data so that we can answer the physician's specific questions that you saw answered there. How many dollars am I using in lab and pharmacy? And oh, by the way, which of these drugs am I using inefficiently?
Okay, thank you. This next attendee asks, do you envision the individual physician fees within their specialty will be based upon their individual performance or divided equally among the specialists?
Very good question. What I just showed you a second ago was how to divide the dollars between the orthopedic surgeons as a clinical group and the cardiologist as a clinical group. That takes it down to the clinical group level. But because in some hospitals, we can now take this down to the individual lab test, down to the Band-Aid, if you will. I envision in the near future, we will be able to show the physicians and their own performance. The only way you can do that is to have a physician order entry mechanism so that I can see that Mullen Brock ordered this test and not that test. I envision that as we get more and more specific, we will be able to show each physician how efficient they are and exactly what they ordered and what they didn't order. For the most part, we can't get there in most hospitals at this point, but we can take it down to the individual service level and divide it equally among the orthopedic surgeons. And then they can determine among themselves who should get more based upon maybe number of cases or however they want to do it. But eventually we will get there using CPOE technology to show each physician how many dollars each ordered.
Thank you. This next question is, our hospital has risk-adjusted data, but we're not using it with the doctors as you have described. Would your people use our data and work with our doctors?
Yes, Varus would be happy to use whatever data you have, and most hospitals, by the way, do have risk-adjusted data. That's why I said early on here, I just wanted to give you some ideas of how you might want to use your own risk-adjusted data. But to answer this inquiry, yes, we would be happy to come in and use your data to take the data down to this level. We can show you how to do that. And our goal is not to stay in there. Our goal is to do this in the first year and then transition that to a person or two in your hospital. And then by the third year, we would anticipate being gone. I mean, we're not in there to do this indefinitely. We want to teach you how to do it and then leave.
Okay, thank you. This next question is two parts. When working on the breakdown of costs and development of the variation graphs, are these numbers typically able to be obtained through standard information systems, or does it take a significant amount of report writing and conversion? And when working with Varus, do they have programs that will help with the data pull?
We definitely, I'm going to answer the last part first. We definitely have the ability to pull that data out of the lab pharmacy and X-ray in your organization. The first part of the question really is dependent upon your data system of how granular we can get that data. We have hospitals in both areas where we can't get it down to the granular area, but we can get it down to the service level, that is our lab pharmacy X-ray level. And some we can, depending on what systems you have, we can get it down to the Band-Aid level, if you will, to the very, very granular. But again, that's dependent upon what system the hospital has. But we can certainly take it down to the lab pharmacy and X-ray, which is really where we need to go to get started to help the physicians reduce their variation.
Great, thank you. This next question is, how was doctors' reaction to this granular data analytics? Don't they consider it and create friction in organization because of the micromanagement?
Quite frankly, that is not our experience at all. Physicians are data animals. Everything we learned in medical school, all the changes that we make in our practices are based upon clinical data. And when you go in with clinical data that they understand, and they understand is not geared toward simply making the hospital more money, but is actually down to this level so that they can actually improve the clinical outcomes of their patients, we find them to be very, very compliant and actually will start to ask for the data. Again, there will be some physicians who will say, I don't want to participate. They don't have to. But also my experience is that you continue to show them those data because they're data animals, they will start to look at those data and start to make some changes irrespective of how much they protest.
Okay, thank you. We do have time for a couple more questions. This question is, are you mainly working with physicians that take care of privately insured patients or CMS insured patients?
We both, because we never do these kinds of analysis using only one group of data. That's why I said at the very early on, we only use the MedPAR file to show a hospital how much variation and the doctors how much variation they have. It's just a basic high-level guide. We always use all the patient's data for these analysis because doctors don't treat private fee-for-service patients differently than they do Medicare patients. We want to show them in all their cases, and we don't differentiate. We can differentiate, but we don't. We want to just show them where they're more efficient in congestive heart failure or total hips, irrespective of the patient's payment method.
Great, thank you. The last question we have time for today is, what standard do you utilize when stratifying the quality measure into 5 levels of acuity, as MSDRGs are typically 3-tiered?
We take each, a very good question. We take each of the 3 tiers, whether you're talking about the pneumonia without complications and the pneumonia with complications, and we break each of those down into 5 levels of acuity. So we risk adjust each of those DRGs, even the ones with the triads.
Okay, thank you, Dr. Mohlenbrock. Again, I want to thank you for your excellent presentation and for all the attendees who participated. Thank you for hanging with us there during that technical difficulty. We look forward to having you join us for future webinars. Dr. Mohlenbrock, is there any last words you want to say to the audience before we conclude?
Yes, I knew that the state of Illinois was in trouble, but I didn't know you weren't paying your fees for your internet access. So let's tell the governor to get on the stick.
I think that's a great idea. We will do so.
Anybody
this concludes today.
Yeah,
Go
anybody
ahead.
who wants to contact me, you can give me a call on the phone or my email or whatever, and I'll be glad to answer your questions. I certainly appreciate all of you hanging in there throughout this sort of trying time with the internet, but hey, you know, we appreciate it.
Great. Thank you very much. This concludes today's program. Everyone have a wonderful afternoon.